Hello, this is Mike, welcoming you to another edition of the Addiction Pharmacy podcast. Our special guest today is Mr. Scott Pino, a friend and colleague who has been working in the behavioral health field for over 28 years. His experience is in a multitude of different areas: crisis intervention, inpatient, child, adolescent care, adult geriatric units, administrative supervisory time, working with consumers, professionals, various systems in the behavioral health care field. Currently working in a psychiatric unit where he is going to share with us some insight and experience that he has in caring for individuals with those needs. Scott and I hope to talk about some of the substance use that they've been seeing there and some of the complexities and challenges that the mental health and substance use field presents to caring appropriately for these patients. So welcome, Mr. Scott Pino, to the Addiction Pharmacy Podcast. Welcome to the Addiction Pharmacy Podcast. We have a great guest tonight in Scott Pino. During his introduction there, I shared with you all the places that Scott has been and positions that he's held, and he is with us today. Welcome, Scott.
Hey, thanks for having me, Mike.
You are welcome. Scott and I have known each other and worked together for a while, and I was really glad when he said he'd come on and help us out with some important stuff to discuss here. To get started, Scott, why don't you, I know we've discussed a little bit about, or I introduced you as having various positions. Can you share with us right now the position that you've held for the last how many years?
For about the last 8 years now, I've been with Sharon Regional Medical Center. My formal title there is Outreach Coordinator for Behavioral Health. Primarily, I oversee our social work department and all of our behavioral health liaisons who handle all of our incoming referrals, all our ER folks that we see through our ED and on our med-surg floors.
Excellent. So you and I have talked in the past about the types of patients that you need to help and who comes through there. Can you give us an idea of what kind of patients you're seeing on a daily basis?
Sure, absolutely. Because we're licensed as a mental health unit, primarily we are looking at mental health diagnoses. But we get a lot of phone calls and a lot of calls down to the emergency room or over to med surge, um, based on folks who may come in intoxicated, who may come in under the influence and appear that they may be psychotic. In a lot of those instances, it can be hard to tell, especially if it's somebody that we're not familiar with. It can be very difficult to tell whether, it's a psychotic episode or is it a substance-induced episode? Is somebody intoxicated or under the influence that is causing these behaviors? Especially with some of the drugs that we're seeing out there now. But in my years of being back at the hospital, and in my previous experience, um, lots and lots and lots of folks on the mental health side have a co-occurring substance use disorder as well, and vice versa. Folks with a primary substance use disorder often have, an underlying mental health diagnosis as well. So, um,
And we have discussed that in many areas where I've been working, that the two are really interwoven very tightly in some people. And the whole idea of a co-occurring slash dual diagnosis, as we used to say, really presents itself in the work that you do. And is that a difficult disentanglement for someone who's listening? Is it something that special skills in your personnel are needed? How do you proceed in determining what's going on right here?
well, I mean, fortunately for us, we are a psychiatric unit located in a medical hospital. So we do have emergency rooms. So we do a lot of, UDS, a lot of urine drug screen testing that can help us make that determination. But in addition to that, being in a small rural area, we often know our patients fairly well, and we know what their histories look like. So in a lot of those instances, if we know somebody that comes in who maybe appear to be hallucinating or responding to internal stimuli that actually does not have a diagnosis that would lead them to that, we're going to look for substances. We're going to look for those substance induced kinds of things. Also, for us, we use a lot of collateral information. So we will talk to case managers, we will talk to peer specialists, we will talk to family members, anybody who may know the individual that can help give us some background, will help us kind of sift through potentially whether this may be a substance induced issue or whether it may be a underlying psychiatric issue.
Do you see any kind of patterns or any tip-offs that would have some mental health symptomology that then would relate to a particular substance, what you're seeing now in your area?
To be honest with you, it varies. It can vary greatly. Typically, what we tend to see as far as substance use tends to be kind of whatever the substance of the day is, as well as what can be purchased relatively cheaply. Um, a lot of our individuals, um, are not able to work full time. They're chronic mental health patients, and in so as such, they live on a relatively fixed income. So typically, we kind of see kind of what's happening in the community, what's cheap, what's easy to get to, those kinds of things.
What about the use of like some psychoactive meds, our mental health meds in treating some individuals? Do we see um, discriminating use? Are the drugs overused in these situations? And do these patients then provide a challenge for the substance use treatment community in getting them the help they need?
Well, we've been really fortunate. I think here in the Commonwealth of PA, there has really been a lot of work done over the last several years to try to kind of streamline and do more of the warm handoff and direct contact between medical facilities, behavioral health, psychiatric facilities, and substance use providers.
Mhm.
Um, I think that's been a great movement compared to 25 and 30 years ago when I started in the field, and it was kind of they'd show up for a mental health assessment and we'd say, we can't assess you until we know you're clear from all substances. So you need to go over to the SCA and get your treatment, and then you can come back and see us. And they'd go over to the SCA, and the SCA would say, of course you're depressed, you're manic, you're mentally ill. We can't get you off the substance until we know your mental health is stable. And we would just send them back and forth, and they kind of would eventually just give up.
Mhm.
More recently, there's been a lot of work done. Um, I know initially here over the last probably 5 or 6 years, a lot of work done because we were seeing a lot of use of prescription narcotics, the opioid epidemic that has been kind of across the country. A
Mhm.
lot of work was really done to narrow that down and take those things kind of out of circulation and make it more difficult to get to those. But we started to then see kind of a resurgence in the use of crack cocaine, more recently, probably methamphetamine. And
Mhm.
it can be extremely difficult with some of those drugs to tell the difference between what is a psychiatrically induced psychosis and what is a substance induced psychosis. For us, for the most part, we typically go about treating them the same way. We will typically use the most available atypical antipsychotic type medications. In some cases, we'll use the older psychotropic medications, the older antipsychotics like Haldol or Thorazine, um, not just because of the antipsychotic effect, but because of the sedative effect.
Mhm.
Because these individuals that have been using methamphetamine often come in on days and days and days without sleep. So sometimes the lack of sleep can induce the same kind of psychotic type symptoms. So it can be very difficult to kind of dig through and figure out, is it a lack of sleep? Is it the drug itself? Is it an underlying psychiatric disorder? So again, we rely a lot on collateral information, as much information as we can get from whatever sources we can get it from, to make our best reasonable diagnoses and move from there on how to treat.
So what type of a time period are you talking about where an individual will be sedated and, as we would say, sleep it off and then be a little more of a compliant patient to work with?
On the methamphetamine side, it's probably a couple of days worth.
Mhm.
And not all of the folks that we see that come in who receive those medications immediately are just to sleep. Oftentimes it takes a couple of days worth of dosing to get them to kind of slow down enough to the point that their body can take over and kind of shut itself down in a natural way to let them sleep. But typically, then we don't see a lot of activity from those folks, sometimes for anywhere from 2 to 3 or 4 days. A lot of sleep, a lot of recuperation. And
Mhm.
then when they kind of wake up, we see a completely different side of somebody. Um, Oftentimes, the hallucinations that were there, the paranoia that we typically see with those kinds of substance induced psychoses, typically just disappear. Um, and so that gives us a better gauge as well on the fact that it was more than likely due to the substance use and not so much due to an underlying kind of schizophrenic disorder or, psychotic bipolar disorder or anything like that.
And then I would imagine that your job, your staff's job is then to try to persuade and refer an individual to get ongoing care in a substance use treatment type program.
Yeah, we have to be really careful about that because of the fact that we are a psychiatric unit and not licensed to do any kind of substance abuse,
Mhm.
you know, service provision. But we can talk about those kind of things. A lot of the times, what we'll do, we're fortunate in Mercer County that we have a bridge program that is provided uh, by substance use specialists and providers that are licensed. So a lot of times we will engage them while the individual is on our psychiatric unit. Most of them have been trained in motivational interviewing. They've been trained, to come in and make those connections, and they have those relationships with inpatient providers, outpatient providers, partial providers, and they're able to get us a direct link so that when the person is ready to leave our facility, they're directly going into treatment.
Okay, good. Because I just know of stories of individuals, family members, who get a little confused where the mental health aspects of their loved one or their own care starts and ends, and then how do we address the substance use problem where it kind of goes back and forth, as you were saying earlier, and some of the treatment providers were hesitant to
Mhm.
to accept a person because of this outstanding mental health problem. And a lot of folks then end up in these larger hospital systems that are tasked or qualified to care for them, and that's not available everywhere.
Right. One of the things that we really try to do to make that better for our substance abuse provider partners is to be clear in our documentation
Mhm.
so that when someone comes into our emergency room who may have been, you know, awake for a week, using methamphetamine, presenting as psychotic. I mean, obviously, that's all going to be what gets documented in the emergency room and through the docs who are originally laying eyes on these folks. Our doctors, my social work team, our staff right on the unit, our nursing staff, try to be very clear about those symptoms and when we see them dissipate and how we see them dissipate. A lot of times, again, it's an automatic where someone with a psychiatric diagnosis and a mental illness tends to kind of fade off more. The symptoms improve
Mhm.
over time. Typically, with these folks, it's like the crash happens, they sleep for several days, they wake up, there's absolutely no more psychosis, it's gone. So we're very careful about documenting those kind of things and the way we document them to try to give that clear picture as well to our substance abuse partners so that they can kind of take from that, this looks more like a substance use issue than a psychiatric issue, so that they're also not trying to take on things that they're not trained, licensed, credentialed to do.
Yeah, and my understanding from what we've discussed in the past and looked at is that individuals with a methamphetamine use disorder that are not as likely or will not lean into accepting treatment because of historically, the treatment industry partners, as we said, don't have a lot to offer for medication for methamphetamine use as opposed
Right.
to say an opioid use disorder. And that hasn't been as, firmly established as a treatment modality to offer. So, what do you see happening with individuals who may stabilize on your unit, um, and then they're in this position of, I'm a methamphetamine user. I've gotten some rest here. I've kind of stabilized. What's the thought process that you see some of these folks go through?
Well, again, in the time that they're there, it can be very difficult to do, but with what we see, again, individuals with psychiatric diagnoses, even depression and anxiety type disorders, um, the percentage of those folks with a co-occurring substance use or alcohol use disorder is very, very high.
Mhm.
So from our perspective, although it may or may not be quote unquote the root of the problem. Again, someone comes in, they're hallucinating, they're very paranoid. We can suspect it's from the methamphetamine. We're also going to look at everything else that's going on with that individual. What kind of support system do they have? Have they ever been treated before for depressive disorders, anxiety disorders? Are there other things that we can do while at this moment in time, the pressing issue may be the substance use disorder? There's probably pretty likely an underlying mental health issue somewhere in there too, some depression, some anxiety, something. So we're going to try to make those connections. We're going to try to let these folks know that we're still there to help them. We may not be the end all for their treatment, and we may be trying to set them up to go to, a rehab facility or, partial programs for substance use. But at the same time, we're not going to completely say, oh, this was just methamphetamine use. Have a nice day. Go get your substance use treatment, and you'll be fine.
Mhm.
We still want to work with that individual to find out what kind of supports can we help foster. What else can we do for them? What other treatment have they been on? Have they been on meds in the past? So again, that historical view and that collateral information that we can collect allows us to make those connections to hopefully make these folks successful once they leave us.
Great, thanks, Scott. I was just hoping to get you to say some of those things through our talk here, so anybody listening would really start to appreciate the complexity of what some individuals bring and the value that the work you do and the folks you work with offer and can help some people at this very critical time, coming from the ED, coming into the hospital, landing on your unit, and then having to determine right there where's this individual's needs and what can we do for them. So I'm glad you were able to express that and bring this all to this talk.
Sure, I appreciate that. And it oftentimes for them is a very confusing period as well. I mean, these folks may or may not be completely under control when they come in, of their own thought processes, their own behavior. So it's pretty scary for them too. And uh, as you're aware, and I'm sure probably most of your listeners are, the difference between psychiatric treatment and substance use treatment is way different. My facility is a locked unit. You come on my unit, you're not leaving when you want to leave. You're going to do what needs to be done kind of situation. So even that in and of itself can be very scary for these folks. But in a lot of those instances, again, we try to work with them and say, look, we're going to get you out the door as fast as we can. However, here's our recommendations for you. This is what we think will be the best successful path for you. And again, when we can, um, we love to use certified recovery specialists, folks who have been in their shoes, folks who understand the process. We love to use, our pros. We like to bring those folks into the unit when we can and make those connections right there because it makes them more comfortable. We also feel that it makes them way more likely to engage and stay engaged in their substance use treatment. So we try to do that wherever we can, and we think we've been pretty successful with that.
That's good. A lot of great information. Thank you, Scott. Appreciate you coming on. Appreciate all of your input. and your lengthy experience and wisdom in all of this. I hope to talk to you soon. And if there's an opportunity to follow up with this on the podcast, I hope you'll do it.
Absolutely, Mike. All you need to do is reach out.
All right. Thank you,
I
Scott.
appreciate your time.
All right. Thank you, Scott Pino, for all of that great insight and sharing with us at the podcast your experience over all this time helping the individuals that you do. Scott's a wealth of information, a good friend, and we are so happy to have had him on the Addiction Pharmacy podcast. Thank you all again for listening, and have a good day.